This is the importance of the CTZ. It contains D2 receptors, 5-HT3, and also neurokinin 1 receptors or neurokinin A receptors. Neurokinin A receptors, yeah, for substance B. Neurokinin 1 or neurokinin A receptors for substance B. So for each of these receptors, we have blockers to block the chemoreceptor trigger zone further stimulation or further triggering to the vomiting center. And the vomiting center here is rich in muscarinic muscarinic receptors, cholinergic muscarinic acetylcholine receptors. So therefore, to block the vomiting center, we can benefit from anti-muscarinic agents. To block the chemoreceptor trigger zone receptors, we use anti-dopaminergic agents or drugs, or we use anti-serotonin receptor drugs, antagonists, or we use substance P antagonist at the NK1 neurokinin 1 receptors. So this is how we should understand the action of the toxins or the drugs that especially we are talking about the drug induced nausea and vomiting, the chemotherapy. This is how we should understand the relationship between the drugs and the receptors on the chemoreceptor trigger zone on the CTZ and the vomiting center. On the other hand, if we want to understand a little bit the anticipatory nausea and vomiting, we have to go up. If you can follow the pointer, you can follow my pointer. You can see here sight, smell, emotional factors. Emotional factors includes memories from the past, and memories from the past includes previous injection of the chemotherapy agents. So this will affect the sensory, efferent, and CNS pathways, the cerebral cortex, higher centers, integration, and this will directly stimulate the vomiting center muscarinic receptors, as you can see in the diagram. It has nothing to do with the CTZ. So if the patient is having anticipatory nausea and vomiting because he has a previous bad memory from being treated with chemotherapy anti-cancer agents causing severe nausea and vomiting. So this bad memory actually will not stimulate the CTZ receptors. It will stimulate or it will have a pathway, different pathway, which is related to the higher center in the cerebral cortex, which directly send or triggers the vomiting center. So for this kind of nausea and vomiting, we call it anticipatory nausea and vomiting. We need to block or we need to stop the anxiety of the patient. We use anxiolytic agents. And among the anxiolytic agents, we use GABA receptor stimulants. We use GABA receptor stimulants. We will come to it later on. So this is the important thing that how we should understand and how in order to treat. How we should understand the receptors in order to treat. The other one the other important thing is the motion sickness. See the motion sickness here at the stimulus level. Motion sickness is what is vibration, which can be easily perceived by the labyrinth system of the ear, especially in hypersensitive individuals. And those vibration stimuli will stimulate from the labyrinth. The labyrinth will send signals to the vestibular nuclei, and the vestibular nuclei here is rich with H1 receptors, histamine 1 receptors, and muscarinic acetylcholine receptors. So in order for a patient who is hypersensitive to vibration, leading to hypersensitive labyrinth system in long traveling, he travels by the ship, for example, or travels by air, or traveling even by car, long distance between cities, intercity traveling. So this can progressively stimulate the vestibular nuclei, H1 receptors, and muscarinic receptors. If we try to treat those patients with dopamine receptor antagonists that we use, for example, for the treatment of drug-induced nausea and vomiting, it will not benefit them. because the types of the receptors that cause the stimulation are different. Yeah, they are histamine and muscarinic receptors. So we need histamine H1, specifically H1 receptor antagonist, and muscarinic anti-muscarinic agents that can cross the blood-brain barrier to reach the vestibular nuclei. To reach the vestibular nuclei. So if we use H2 receptors antagonists, like for example the drugs that are used for treatment of peptic ulcer, we use cimetidine, ranitidine, nizatidine, famotidine. Do you expect any benefit from these histamine antagonists on motion sickness patient? On a patient with motion sickness, the answer is no, because the type of the receptor is not histamine 2. And the peptic ulcer treatment agents, antihistamines, are selective H2 receptor antagonists. So we need a non-selective, or we need a selective H1 receptor antagonist, like the drugs which are used for the treatment of allergy. Yeah, anti-allergic drugs that can penetrate the blood-brain barrier. Yep. So this is how we should understand. This is how we should understand how the receptors, so that we can understand the treatment that are related to blocking each one of these receptors. This is another uh, diagram which shows the mechanism of that triggers the nausea and vomiting. Higher centers, we mean memory, we mean sensory smells, sensory stimuli, smelling, seeing, or even tasting. Okay, that can trigger directly the vomiting center, and the vomiting center is the executive part of the pathway of nausea and vomiting, while the CTZ is the is the receiving center to receive whatever is circulating of the anti-cancer agents, or the drugs that can stimulate the dopamine, or the 5-HT serotonin receptors on the chemosynthetic trigger zone, or even the neuropilin A receptors, or neuropilin 1 receptors. Urea, excessive urea in the condition we call it uremia, excessive urea in blood, which end up the patient with uremia. The urea in blood can reach the CTZ, also can trigger the receptors there. Uh, for motion sickness, as we have mentioned, it has another level before reaching the CTZ. It has another level as the vestibular nucleus, as we have just mentioned. Yep. All these will stimulate the vomiting center, which is the executive center, which means it gives efferent signals to the muscles, to the phrenic nerve, through the phrenic nerve, through the vagus nerve, through the spinal efferent nerves, causing retching and vomiting. So in order to understand the antiemetic activity, as you can see here, of the antiemetic agents in the middle, okay, we have many antiemetic agents, different classes. These are classified according to their receptor type, according to this in this figure that we see in the middle. So phenothiazines, for example, and the example is prochlorperazine. These are dopamine receptor antagonists. Dopamine D2, specifically D2 receptor antagonists. They are considered as the phenothiazine are considered as high high antiemetic activity agents. High antiemetic activity agents. The 5-HT3 serotonin receptor blockers, which includes the lacitron, granisetron, ondansetron, holonosetron, all these that ending with the suffix of citron, all these are serotonin 5-HT3 receptor antagonists, and they are considered as high efficacy antiemetic agents. The highest efficacy so far antiemetic agents has been discovered so far are the 5-HT3 serotonin receptor antagonists. Okay, although they are costly, although they some of them like dolacitron have some side effects on the heart, like prolongation of QT interval prolongation. Okay, uh, but it's still they are still considered as drugs of first choice. It has to be included in the antiemetic therapy of any patients taking chemotherapy or anti-cancer agents. Yep. Substitute benzamides, metoclopramide is the representative of this group, and it is a dopamine receptor antagonist, both centrally and peripherally. Centrally, because metoclopramide can cross the blood-brain barrier. Okay, it's highly lipophilic agent, highly lipid soluble agent, and peripherally means at the level of the gut of the GI tract. It also blocks the dopamine receptors at the mesenteric plexus, leading to increasing peristaltic activity and acting here as a prokinetic agent at the level of the stomach. So pentaclopramide can have both central action and peripheral action lower down at the level of the GI tract. And at the level of the GI tract, it increases peristalsis. Therefore, it reduces the gastric transit time. So by reducing the gastric transit time, the food and the meal, whatever is in the stomach, will transit at a shorter time than usual, which means lower chance of nausea and vomiting by by reducing this the transit time in the stomach. Butyrophenones are also dopamine D2 receptor antagonists. Usually, those drugs are antipsychotic drugs used for the treatment of schizophrenia. Used for the treatment of schizophrenia, but they have an important role as antiemetic agents since they are potent dopamine receptor antagonist at the CTZ. So to understand, although these drugs can lead to significant what we call extrapyramidal side effects because they can cross the blood-brain barrier, leading to blocking of the dopamine receptors on the basal ganglia or the basal nuclei. And by this blocking, it can lead to the appearance of the side effect of extrapyramidal side effects, which are like considered as like Parkinson's-like syndrome, causing Parkinson's-like syndrome, like tremor, yeah, like difficulty in initiating movement, hypokinesia, yep, uh, the flattening of facial features. All these are considered as Parkinson-like side effects from dopamine receptor antagonists that can cross the blood-brain barrier. But they are still still being used for the chemotherapy because they are considered as efficacy, intermediate efficacy anti-emetic agents. Intermediate efficacy. Benzodiazepines, those are the drugs that are considered as GABA receptor stimulants. GABA receptor stimulants. So by stimulating GABA receptors, which are present at the cerebral cortex like alprazolam and lorazepam, these are drugs that we are going to discuss later on in the CNS in detail. So these are drugs are that are important for the treatment of which kind of nausea and vomiting. Uh,
Anticipatory.
yes, thank you so much, Faiza. Thank you, Amir Faiza. Anticipatory nausea and vomiting. Anticipatory nausea and vomiting is has a different mechanism as we mentioned just now before in the beginning of the lecture. So we need a different strategy other than the dopamine receptors antagonist, other than the serotonin 5-HT3 receptor antagonist. We need a different pathway to block. We need to block the pathway of the cerebral cortex, which can directly trigger the executive center, the vomiting center, which is the executive part of the pathway of the vomiting pathway.